Welcome, surgeons. I'm Vasi, the vascular artificial intelligence created by Dr. Mohammed Amr El-Faraq. Today, we're diving into a pre-operative briefing and explainer focused entirely on Chapter 2, Vascular Embryology and Anomalies. My goal here is to optimize your cognitive map of how the vascular system originates. We want to make absolutely sure you're fully prepared for whatever anatomical curveballs you might encounter on the operating table. So let's get this briefing started. Right out of the gate, we need to establish the clinical stakes. As you well know, failure of the vascular system to properly develop can result in severe anatomical variations. Embryogenesis isn't just some fascinating history lesson about how humans are built. It's the direct, functional blueprint for the anomalies you diagnose and treat in the OR every single day. Having a deep grasp of these developmental pathways, that's exactly what separates a routine procedure from a sudden, unexpected surgical crisis. Here is our briefing agenda for today. We'll be moving systematically through 5 key areas. Number 1, embryogenesis, the first blood. 2, architecting the aortic arch. 3, perfusion of the limbs. 4, mapping the venous system. And finally, 5, origins of lymphatic vessels. Let's jump right into Section 1, embryogenesis, the first blood. For the first 3 weeks of gestation, simple diffusion is enough to sustain the embryo. But as the organism rapidly expands, diffusion quickly hits a physical wall, and the sheer speed of early vascular formation becomes pretty staggering. I mean, look at this timeline. By day 17, isolated blood vessels are already forming in the yolk sac. By day 22, the primitive heart muscle is actually twitching. And just 2 days later, by day 24, it's actively pumping blood through a closed loop. The cardiovascular system has to be one of the very first functional systems to come online, simply because without it, development literally halts. Now, it's absolutely vital to understand how molecular signaling dictates vessel identity. You might logically think that arteries become arteries just because high-pressure blood gets pumped into them, right? Actually, scratch that. Vessel identity is permanently locked in long before the first drop of blood ever flows. Arterial differentiation is driven by vascular endothelial growth factor, or VEGF, which activates Notch and results in FB2 expression. On the flip side, venous differentiation is commanded by CUPTFII, which actively suppresses Notch and leads to EB4 expression. The vessel's molecular destiny is completely pre-written. Moving on to Section 2, architecting the aortic arch. Let's look at the embryonic blueprint of the thorax. We start with 6 primitive pairs of aortic arches emerging from the aortic sac. While this setup looks beautifully symmetrical at first, nature is about to do some heavy remodeling. Arches 1, 2, and 5 rapidly disappear in humans. It's really the 3rd, 4th, and 6th arches that lay the crucial foundations. The 3rd becomes your carotids, the asymmetrical 4th forms the true aortic arch on the left, and the proximal right subclavian on the right, and the 6th establishes the pulmonary arteries as well as the ductus arteriosus. Because this remodeling process is so complex, it leaves immense room for anatomical variation. You should absolutely treat these statistics as critical predictive data for your preoperative planning. Only about 65% of the population actually has that textbook normal arch development. A massive 15 to 30% present with a bovine arch configuration, where the left common carotid originates right from the brachiocephalic trunk. As a surgeon, you have to anticipate these patterns before you ever advance a wire. And here is how that embryology translates directly into pathology. What you're seeing here is a classic coarctation of the aorta, complete with post-stenotic dilation. But why does this happen? Well, oxygen-sensitive smooth muscle tissue from the ductus arteriosus gets abnormally incorporated into the wall of the aorta itself. So when the infant takes its very first breath and oxygen tension spikes, that misplaced tissue constricts completely inappropriately, creating a permanent anatomical narrowing. Before we leave the thorax, consider this quick clinical warning regarding the 4th arch. An abnormal involution here can leave your patient with an aberrant right subclavian artery, taking a retroesophageal path. While it's often asymptomatic, this anatomical detour can compress the esophagus and cause a swallowing difficulty known as dysphagia lysoria. Not only that, but these patients are at a distinct risk for aneurysmal degeneration at the vessel's origin, a dangerous condition termed a Camarel diverticulum. All right, Section 3, perfusion of the limbs. As the vascular supply carefully navigates into the rapidly growing limb buds, it encounters a development process fraught with unique variations. In the upper limbs, the brachial artery descends from the axial artery, but the branches in the forearm are incredibly dynamic during development. This leads to 2 vital anatomical variances you need to be ready for during peripheral interventions. Roughly 14% of patients will have a high origin of the radial artery branching off proximal to the cubital fossa, and up to 12% will feature a persistent median artery extending all the way down into the palm. Now, the lower limbs undergo an even more complex handoff of blood supply. Initially, the sciatic artery, which is an extension of the internal iliac, serves as the main supply line down the leg. Next, the external iliac develops into the iliofemoral system. Finally, the sciatic artery mostly regresses. During this handoff, the deep popliteal artery regresses and is literally replaced by the later developing superficial popliteal artery, which sits right behind the popliteal's muscle. But what happens when that handoff fails? In an extreme rarity, occurring in only about 0.05% of cases, the iliofemoral system completely fails to develop. When this happens, the embryo retains a persistent sciatic artery as the dominant vessel supplying the entire thigh. Recognizing this extraordinarily rare variant is absolutely paramount to preventing limb loss in the event of an occlusion. Section 4. Mapping the venous system. If the arterial system is a nicely structured tree, the venous system is much more like a chaotic, sprawling web. Let's decode those early embryonic venous plexuses into the structured systemic veins you rely on when reading modern CT scans. At 4 weeks, we have 3 primary pairs to track. The vitelline veins drain the yolk sac and ultimately forge the portal system and parts of the IVC. The umbilical veins bring placental oxygen and mostly regress into the ligamentum teres. And the cardinal veins, which drain the embryo itself, establish the blueprint for our superior vena cava, the azygous system, and the rest of the inferior vena cava. Let's look at a real-world manifestation of this highly complex development. The scan we are looking at reveals a retroaortic left renal vein running posterior to the aorta. Remember how the left renal vein forms from an embryonic venous collar that normally loses its posterior component? Well, if the anterior component happens to regress instead, you're left with this exact situation. This is a perfect example of where knowing your embryology directly dictates your surgical success. I literally cannot emphasize this next point enough. During dissections of the abdominal aorta, particularly at the level of the renal arteries for aneurysm repair, you must actively watch for the persistence of a retroaortic left renal vein. If you fail to recognize this embryonic remnant, it can lead to a catastrophic, incredibly hard to control venous hemorrhage right in the middle of your procedure. And finally, Section 5, Origins of Lymphatic Vessels. Operating as a distinct fluid transport network that matures very closely alongside the veins, the lymphatic system is governed by powerful transcription markers like PROX1 and SOX18. It emerges around week 5, developing from 6 primary lymph sacs. Interestingly, recent evidence actually points to a fascinating dual origin, showing these cells arise from both venous endothelial cells and non-venous mesodermal precursors. Ultimately, these discrete sacs sprout, extend, and fuse together to form the thoracic and right lymphatic ducts, completing the body's fluid transport loop. So, what happens when this delicate genetic orchestration falters? Mutations in critical developmental markers like SOX18 disrupt this entire dual origin sprouting process. This failure of normal dermal lymphatic development isn't just an academic curiosity. It connects directly to the debilitating clinical presentation of primary lymphedema, where interstitial fluid just accumulates without an exit strategy. Which brings us to the very frontier of vascular surgery. As we increasingly decode the molecular signaling, the VEG, the Notch, the SOX18, of embryonic vascular genesis, we have to ask a bigger question. When will our anatomical knowledge evolve into targeted, definitive therapies for vascular disease? Are we approaching a time where we might grow or repair vessels from scratch? It's definitely something to ponder as you scrub in for your next case. I am Vasi, concluding this briefing. Thank you for utilizing this explainer. Keep your scalpel sharp and your anatomical mapping sharper.